Welcome to the deep dive. You know, if you take a finger right now and just sort of trace it horizontally right over your eyebrow, you're actually running it along the outer wall of this incredibly intricate, millimeter-precise cave system.
Yeah, it's something we completely ignore until we get, a headache or a stuffy nose.
Right, exactly. Or that really intense, heavy pressure right behind the eyes. And when that happens, it's easy to think of your head as just a solid block with a couple of hollow plumbing tubes that have gotten clogged up.
Oh, absolutely.
Yeah.
But if you could actually shrink down and step behind your own forehead, you would not find simple plumbing.
Right. You'd find a highly sensitive, wildly variable anatomical maze. And navigating that maze surgically when something goes terribly wrong is, well, it's a high-stakes art form.
It really is. It's an environment where the margins of error are basically non-existent. The geography inside the human face is spectacularly complex.
You're just so close to everything important.
Exactly. We're talking about a living, highly reactive ecosystem where the physical borders of that cave system are quite literally the floor of your brain and the wall of your eye socket.
Okay, let's unpack this, because today we are taking you straight into that hidden maze. We're doing a deep dive into a stack of surgical guidelines, operative manuals, and clinical data from Chapter 112 of Operative Otolaryngology Head and Neck Surgery.
A very comprehensive test.
It really is. And our mission today is to map out exactly what it takes to safely pull off endoscopic frontal sinus surgery. But, before a surgeon even picks up an endoscope, they have to decide if cutting into this space is actually the right call. So who is actually getting pushed into the OR for this?
Well, the primary candidate is someone suffering from chronic frontal sinus disease. But the key word there is definitely chronic.
Right, so not just a bad cold.
Exactly. No, this is only considered after maximum medical therapy has entirely failed. We're talking about patients who have gone through weeks of aggressive regimens.
Like steroids and antibiotics.
Yes. Multiple rounds of steroids, antibiotics, saline rinses, and their internal tissue is still intensely inflamed. The sinus is essentially a trapped pocket of infection that just won't drain.
Wow. But there are acute emergencies too, right? I saw something in the text called hot puffy tumor. I have to admit that sounds a little bit like a cartoon ailment.
I know the name is deceptive, but the reality is severe. It's not actually a tumor in the cancer sense. It's a superior abscess of the anterior table.
Okay, what does that actually look like for the patient?
So to visualize it, a severe sinus infection essentially eats right through the frontal bone of the forehead.
Wait, through the bone?
Yeah, literally. The infection breaches the bone and pools beneath the periosteum, which is the membrane covering the bone, causing this very visible, palpable, doughy swelling right on the forehead.
That sounds awful.
It is. You also see orbital complications like proptosis, where the trapped infection actually pushes the patient's eyeball forward out of the socket.
Out of the socket? That is terrifying. So if it's eating through bone or pushing an eyeball out, you clearly have to go in. But going through these texts, I found a detail that seems totally counterintuitive.
Oh, about acute sinusitis.
Yes. The guidelines state that uncomplicated acute sinusitis is actually a contraindication for the surgery, meaning if you have a really bad run-of-the-mill sinus infection, it is a distinctly bad idea to operate. If a pipe is clogged right now, why wouldn't you just go clear it out?
Because we have to remember, this isn't PVC piping, it's a living geography. In an acute infection, the mucosal lining of the sinus is intensely hyperemic.
Meaning it's full of blood.
Right. The body's immune response has flooded that specific tissue with blood, making it swollen, engorged, and highly reactive.
Yeah.
If a surgeon goes in and manipulates that angry tissue, it's literally a bloody mess.
So you can't even see what you're doing.
Exactly. But worse, the physical trauma of the surgical instruments rubbing against that hyperemic tissue triggers a massive healing response. And as it heals, it forms severe scar tissue in the extremely tight, hourglass-like confines of the frontal recess.
And that scarring just fuses the walls together.
You got it. You trade a temporary medically treatable infection for a permanent anatomical roadblock.
So you try to fix it and you actually break the system permanently.
Yeah.
That makes sense. But speaking of fixing things, there is this fascinating caveat the guidelines warn surgeons about.
The isolated pain caveat.
Yes. They warn that patients with severe isolated forehead pain might not actually get relief from this surgery, even if their CT scan clearly shows a diseased frontal sinus. I really have to push back on the logic.
Okay, let's hear it.
So if my mechanic looks at my car, finds a severely dented exhaust pipe, and tells me, well, I see the dent, but fixing it might not stop your car from rattling, I'd find a new mechanic. If the pain is right over the sinus and it's visibly diseased on an x-ray, why wouldn't fixing the disease cure the pain?
This raises an important question about how we interpret medical imaging versus human biology. Your mechanic analogy assumes a strict mechanical cause and effect.
Right, broken part equals rattle.
But human pain pathways are notoriously deceptive. What the guidelines are warning about is the disconnect between anatomical findings and clinical symptoms. A patient might have mild chronic inflammation that happens to show up on a CT scan that's your dented pipe.
Okay, so the dent is real.
It's real, it's there. But their severe isolated forehead pain might be entirely neurological. It could be a tension headache or a migraine variant. The inflamed sinus is just an innocent bystander living in the same neighborhood as the headache.
Wow, so the surgeon operates, beautifully clears out the sinus, but the patient wakes up with the exact same headache. That is a brutal realization.
It really highlights how much detective work has to happen before anyone even puts on a hospital gown.
So let's say the detective work is done. You've ruled out tension headaches, you absolutely have to go in. How do you know what you were walking into?
Well, you map it out. Because before a surgeon makes a single cut, they have to understand the highly individualized terrain of the patient's frontal recess. The anatomy here is not standardized.
And when the literature says individualized, it isn't kidding. Here's where it gets really interesting. In about 85% of cases, the sinus drains down a normal pathway between two structures, the uncinate process and the middle turbinate.
Right, a typical layout.
But in the other 15%, that uncinate process, which is like a little bony hook, attaches completely differently. It might anchor to the skull base or fuse directly to the middle turbinate itself.
Which radically alters the entire drainage path.
Exactly. It's like buying a house on a normal street and then one day you open the drywall and discover your plumbing runs completely backward from every other house on your block.
That's a great way to visualize it. And a surgeon absolutely cannot afford to discover backward plumbing during the operation when they are, millimeters from the brain.
Which is why CT scans are so vital.
Yes, every single patient gets one. And what's brilliant now is that modern dose-reducing scanners have cut radiation exposure by up to 40%.
That's a huge drop in radiation.
It really is. But taking the picture is just step one. They use software capable of 3D multiplanar reconstruction, or MPR.
Yeah, I saw MPR all over the manuals. What exactly are we looking at there?
The software takes the raw CT data and lets the surgeon view the anatomy in all three anatomical planes simultaneously.
So like top down, straight on, and a side profile.
Exactly. The axial, coronal, and sagittal planes. Imagine a complex 3D maze, and you have crosshairs pinpointing your exact location from all three views at the exact same time. It lets the surgeon spot anatomical danger zones long before scrubbing it.
Danger zones like the anterior ethmoid artery. The diagrams show a major artery right at the back margin of the space. If you're working in a space the size of a thimble, how does looking at a monitor stop stop your hand from slipping and nicking that artery.
Well, it doesn't guide your hand, but it informs your route planning. If you know exactly where that artery is suspended, you know precisely which angles of approach are safe.
So you know which tools are too bulky for that specific corridor.
Right. You also use the 3D map to spot deceptive structures, like supraorbital ethmoid cells.
I saw those mentioned. The manuals say to be suspicious if you see multiple septations, like little bony walls inside the sinus on the scan.
Yeah, a supraorbital ethmoid cell is essentially an extra air pocket that balloons up over the eye socket.
So it's like a decoy sinus.
Basically. If a surgeon doesn't study the 3D planes and mistakes that extra cell for the main drainage pathway, they'll spend the surgery meticulously drilling into a dead end.
And leave the actual diseased sinus completely untouched.
Wow, so you have your 3D map, you know your road, you spotted the danger zones, now the patient is brought into the room. And the setup is incredibly precise. First off, the patient is supine, but the table elevates their head by 30 degrees. That 30-degree elevation is a gravity assist. By raising the head above the heart, you decrease the venous pressure in the face.
Because veins don't pump like arteries do, right?
Exactly, they rely on pressure gradients. Dropping that pressure significantly decreases bleeding. When you're looking through a rigid metal tube in a dark, cramped space, even a tiny pool of blood ruins your visibility completely.
So you tilt the bed to drain the blood and buy visual clarity. But you also have to make sure you aren't visually blind to the borders you're pushing against, which brings us to the patient's eyes being left entirely undraped during the surgery.
Yes, just completely exposed. It is a stark reminder of the exact borders they are working against. The wall separating the sinus from the eye socket is the lamina papyracea.
Which translates to the paper-like layer.
Right. It is remarkably fragile. By leaving the eyes undraped, the surgeon can continuously look at and physically palpate or gently press on the patient's eyes.
Wait, so if they push inside the nose, they can see the eyeball move on the outside?
Exactly. If they see the eye move, they know instantly they are pushing against that paper-thin orbital wall.
That is terrifying, but brilliant feedback. But honestly, the quirk that struck me the most is the anesthesia tube. The manual says if the surgeon is right-handed, the tube breathing for the patient must be taped entirely to the patient's left lower lip.
Very specific, right?
Yeah. Is the surgical real estate really so cramped that a tube on the right side of a lip could ruin the operation?
What's fascinating here is that millimeter-level spatial management defines the entire procedure. Think about the surgeon's body mechanics.
Okay, so standing on the right.
Right. A right-handed surgeon stands on the right, using their left hand to hold the endoscope camera, and their right hand to manipulate cutting instruments. The heavy plastic tubing from anesthesia has to go somewhere.
And if it's anchored on the right side of the mouth?
It physically occupies the exact airspace where the surgeon needs to rest their hands. And it snags the light cords of the camera. In endoscopic surgery, you absolutely cannot have a rigid plastic tube bumping your wrist when your instrument is resting 2 millimeters away from the optic nerve.
That is so intense. Okay, the tube is taped, the space is clear, you enter the nasal passage, the dissection phase, they navigate systematically back to front, medial to lateral. We mentioned the eye wall on the lateral side, but on the medial side toward the center you have the cribriform plate.
The lateral lamella of the cribriform plate specifically. It's the bony floor of the brain cavity, perforated with tiny holes for your olfactory nerves to drop down.
That's your sense of smell. And that bone is exceptionally thin, right?
Often less than half a millimeter thick. Unintended entry means you've entered the cranial cavity, it causes a cerebrospinal fluid leak, or introduces bacteria straight to the brain.
So the surgeon is wedged in this tiny corridor, avoiding the eye to the outside and the brain to the inside. It's like doing bomb diffusal with chopsticks while looking through a periscope.
That's a pretty accurate way to describe it.
Especially because to see up into the sinus, they use angled endoscopes. Cameras with lenses tilted at 30, 45, and even 70 degrees. And the manuals heavily emphasize using reverse post angled endoscopes.
So the reverse post scopes are essential.
I looked up how they work, and the mechanical cleverness is amazing. Usually an endoscope has a heavy fiber optic light cable near the eyepiece. If you use a 70-degree lens to look around a corner, you have to torque your wrist and rotate the whole camera, and that heavy cable swings right into your other hand.
Right, it just gets completely in the way.
So a reverse post scope builds the cable connection 180 degrees opposite to the lens, pointing it up and away.
If we connect this to the bigger picture, it is entirely about ergonomics.
Yeah.
You cannot have cables tangling with your instruments near the skull base.
Which brings us to the cutting instruments. The guidelines give an absolute rule. Use through cutting instruments, like the Hoseman punch. They explicitly say this is to avoid stripping mucosa. Let me make sure I get the mechanism here. If you use a regular grabber to pull bone out, it acts like pulling a loose thread on a sweater. Right. You might accidentally pull away a long ribbon of the delicate mucosal lining along with it.
That is exactly the mechanism. And preserving that mucosal lining isn't just about surgical elegance. It's what keeps the patient from ending up right back on the operating table.
Because of scar tissue.
Yes. When you strip that tissue, pulling the loose thread, you expose raw bone. In a tight space like the frontal recess, it forms synechiae, which are thick, fibrous bands of scar tissue. Those bands will physically glue the sinus opening shut.
So a through-cutting punch prevents that.
Yes, it acts like a tiny, high-precision hole puncher. It sharply bites through bone and mucosa in one clean action. It doesn't tear, leaving the lining perfectly intact, which drastically reduces the urge to form bridging scars.
But what happened to the previous surgeon didn't do a perfect job? The source details revision surgeries, outlining this technique called the frontal sinus rescue.
Revisions are notoriously difficult because your 3D map landmarks are entirely gone, replaced by a chaotic mass of scar tissue.
The manual mentions a lateralized middle turbinate stump.
Right. If a prior surgeon removed part of the middle turbinate shelf we discussed earlier, the remaining stump can scar outward, fusing to the outer wall and blocking the sinus completely.
And the rescue procedure sounds like trying to remodel a closet without scratching the drywall. They meticulously peel the nasal mucosa right off the bone of the stump, cut the scarred bone away, and take that delicate flap of living mucosa to cover the exposed roof of the nasal vault.
It's called a mucoperiosteal flap rotation. By covering the raw bone with healthy living tissue, they deprive the body of the raw surface area it needs to form scar tissue. You're literally paving a new, permanent biological exit route.
That is incredible tissue engineering. So let's say the route is paved, the surgeon backs out. But how do you ensure the body doesn't just heal it shut the second you leave? Because surprisingly, they don't usually pack the nose with gauze anymore.
No, routine packing has largely fallen out of favor. Instead, the focus is on active, patient-driven healing. The patient has to perform high-volume isotonic saline irrigations.
The text said 240 milliliters starting on day 1. That is a massive amount of fluid to push through your face. Why so much?
It's all about physics and flushing capacity. The body's immediate response to surgery is bleeding and weeping fluid containing fibrin, which is the protein that creates scabs.
And scabs turn into scar tissue.
Exactly. The scabs become a scaffold for scars. The 240 milliliters of saline physically washes that fibrinous debris away before it can set.
And then they go back to the clinic for debridements.
Yes, at 1 and 2 weeks. The surgeon uses an endoscope to manually and gently clear out any early scabbing. The aggressive post-op care is the only thing that ensures the opening stays open.
It's a true partnership between surgeon and patient. Now, I want to pivot to the overall data, specifically regarding image-guided surgery, or IGS, the sci-fi navigation system that links the 3D CT scans to the surgical instruments in real time.
Yes, IGS is essentially an indoor GPS for the human head. It uses an electromagnetic field generator around the head or infrared tracking spheres to marry the tooltip to the 3D CT map on a monitor.
So the surgeon sees exactly where their instrument is on the scan, down to the millimeter.
In real time, yes.
It sounds like an absolute superpower, but the clinical data says when they first tested this, most individual studies didn't actually prove it helped patients or prevented accidents.
That's right. For For a long time, the literature was incredibly mixed. An individual hospital might track 50 surgeries with IGS and 50 without, and find no statistically significant difference in outcomes.
So what does this all mean? Because the text then details a massive meta-analysis, pooling data from 14 different studies. And when they combined it all, the picture flipped entirely. They found a massive reduction in major complications for the IGS group.
A huge reduction, yes.
The relative risk was 0.48. That essentially means the risk of blinding someone or hitting their brain is cut by more than half. If the pooled data proves this technology halves the risk of a catastrophic injury, why wouldn't medical boards mandate it in every hospital right now?
That is the exact tension medical boards wrestle with, but it comes down to statistical power. Why did those 14 individual studies miss the pattern? Because, thankfully, major complications in this surgery are incredibly rare to begin with.
So if a catastrophe happens 1 in 1,000 times, a 50-person study will almost certainly miss it.
Exactly. You just didn't have enough people in the room to witness the accident happen. You lack the statistical power. But pool thousands of patients across 14 studies, and those rare events become visible.
That makes total sense.
The safety net of IGS becomes undeniably clear. However, mandating it is deeply complex. IGS equipment is enormously expensive. Mandating it might force smaller rural hospitals to stop offering the surgery entirely because they can't afford the tech.
So you balance optimal safety against practical patient access to care. That is a tough reality. Well, it really brings home the full scope of operating in this space. So to you listening, the next time you have a stuffy nose or that deep localized sinus pressure, take a moment.
Yeah, just think about what's really going on in there.
Trace your finger over your eyebrow and appreciate the incredibly complex, highly individualized, millimeter-precise cave system sitting right behind that bone. And maybe spare a thought for the sheer spatial genius surgeons rely on to navigate it safely.
And consider this. We noted earlier that about 15% of people have frontal sinus plumbing that is anchored completely differently than the norm.
Right, the backward plumbing.
It makes you wonder, if our facial anatomy can vary so wildly from person to person right behind our eyes, what other hidden, highly individualized structural variations are we all walking around with, completely unaware of them, until we need someone to look inside?
Wow. That is a thought that will stick with me next time I look in the mirror. Thank you for joining us on this journey behind the forehead. Keep questioning, keep exploring, and we'll see you on the next episode.